Good afternoon to all those are from India and the Southeast Asia people. It's good morning over here, UK. So I'll be taking this first debriefing session for you all. One or two things I just wanted to say is a case and then few table vivas about the CBS. Few of the students I had taken the case for them. They know the case. They have read this case and attempted it. Other people who have not seen this case, I'll be showing the case and the questions and then can correlate. I don't say that the same case will come, but I have tried to replicate it as it is in the original EDIC exam. In the during the explaining the case and the tables also the CBS, I'll give you few tips how to go about it and what is expected from the students from uh, who are appearing for the EDIC 2. Okay, it will be an interactive type of session, so feel free. You can unmute and ask question if it is there. If you remember some questions or some doubts are there after the session also, you can just send the queries to Furz Academy and I'd be really happy to solve your queries and help you out with the journey in it. Okay, so should we start? Yeah. So first we'll go for the case. I'll describe you the case and the questions how they come. Just 1 minute. So just a few points about examination pattern. For those who have attempted the exam, they must be knowing everything about it. One or two slides for the people who are new to EDIC 2, they are giving their exam for the first time. There are two stations, CCS, it's called the clinical case scenarios, and CBS, that is the computer-based scenarios. In CCS, there is a one long case, two short cases. The watch time for CCS 10 minutes is allowed to read and absorb the opening vignette of each long case and 25 minutes for each examiner to answer the questions put to them by the examiners. Okay. 5 minutes are allowed to read and absorb each of the short cases and 12.5 minutes for questions. Then coming to the point, come to the point and focus on the question content. I always tell my students, just don't go on explaining the things that will not fetch you marks and that will waste your time. Okay. Prompt one or two times. This is for the examiners. EDIC 2 examiners are given liberty. If the student doesn't answer the question correctly, they can give a prompt. They will not tell you the answer, but they will prompt you. The prompt would be in a way that do you want to add something to it? Do you want, can you think of any other thing other than this? So when this wordings comes from the examiner, you should think that either my answer is wrong or I have not given a complete answer. Something is missing in my answer. If your answer will be correct, the examiner will not say anything and he or the examiner will go to the next question quickly. That means they have got what they require, what the answer they want in this question. Okay, so you just remember these things. At the end, candidate cannot go back over the missed question. This is for the CCS, clinical case scenarios. You cannot go back to the questions. In CBS, computer-based scenarios, three main domains, everyone you must be knowing: imaging, curves, and biochemical scenarios. Each CBS session lasts for 12 minutes. Number of pictures or scenarios, expected answers per CBS may vary between 8 to 12. Usually there are 12 in 10 minutes, around 1 minute for one. If you do it quickly, you can attempt all the 12. In curves, usually they are the 4 to 5 usually will be the ECGs, then few CVP line traces, arterial line traces, IBP trace, TEG trace, and some varied kind of trace they will give. For curves, for imaging, mostly they are the X-rays, CT scans, ultrasonography images. MRIs are not a part of this addictive, so don't worry, don't go deep into people go on reading the MRIs and this kind of thing. They don't ask MRI. A very good thing before exam is you can go to the ESICM website and download the 2024 voucher of this exam. The voucher gives you very detailed explanation what things are included and how the things goes. I think everybody should know that. Okay, so curves, images, and then biochemical scenarios. These are the, I think, the most toughest part. Most of us face this, especially the people coming from India. We are not used to this values and quick interpretations. In UK, usually the trainees are trained in such a way that they feel comfortable with these biochemical scenarios and they just interpret it from the patterns. So quite a tough one. When we see so many values, we get confused, but with uh, reading so much, you will be able to solve these biochemical scenarios. Just try to, I'll give you some tips when I tell you the biochemicals. So it is quite tough. What I feel is from curves and imagings. But the good thing is you don't need to pass all the three if you want to clear EDIC 2. If you pass even in imaging and curves, it's okay. Or two of the three you have to pass. Okay. And the last thing is to pass EDIC 2, candidate must pass at least 2 CCS and 2 CBS stations. Okay. With this background, we'll start with the case. This is the Vinet one. You will have 4 to 5 in sometimes 3 or 4 Vinets in each case. So this is a 72-year-old man, known case of diabetes, hypertension, dyslipidemia, presented with acute shortness of breath, with left-sided chest pain for an hour. Sorry. This was not this is the case. I'm really sorry for that slide. By mistake it came. So this was the Vinet which I took for this mock class. It was for the other mock class which I took. This is a 57-year-old referred to the critical care with low GCS 4 by 15. The gentleman is known to the hepatology team and has been admitted under their care for the previous 14 days. Diagnosed with liver cirrhosis related to excess of alcohol 1 year prior to this current admission. On this occasion, the patient had decompensated liver failure precipitated by variceal bleeding. He required endoscopic guided banding and critical care interventions. He survived that episode, proceeded to abstain from alcohol for 8 months. However, he has recently began drinking again. This led to the current admission. Patient has gross ascites, 1.5 liters drained during admission despite medical treatment. Patient has deteriorated over a 24-hour period with a decreasing consciousness level. Okay. These were the labs which were HB is 89, WBC is 19, platelet 98, neutrophil 17, INR is raised 3.2, chloride 92, bicarb 19, bilirubin 92, ALP, AST, GGT, albumin is 22, and amylase is 42. Recent blood gas, which was done on 0.6 FiO2, pH is 6.9, PO2 is 8.4, PaCO2 is 6 kilopascals, the bicarb is 16, chloride is 92, lactate is 3.2, and base excess is minus 4. Now, one important thing, don't get confused with the values, because what happens is most of the Indian people, we are used to not this kilopascals, we are used to mm of Hg for the PO2, CO2, we are used to it, our units are used such. Here in UK, what we use is kilopascals. So now what EDIC people have done since few years is they will give you a value in both the units. So you don't need to worry. Previously, it was very difficult to interpret the things because we are not used to this value. So they will give the values in both the units so that it would be easy for you to interpret whether it is high or low, everything. Okay. So with this background, the first question to you is, please summarize the findings in this case. So in most of the Usually the first question will be this: please summarize the case findings, or it will be, please can you uh, please can you tell the positive findings in this case. Usually it is the first question, not always, but usually it is the first question. So what is the answer? What are the positive findings in this case? Are the patient is having anemia. You don't need to summarize the case, means you don't need to tell about the complete case. You need to tell what are the positive findings. Like there is anemia in this patient, neutrophilia with raised WBC count. Uh, Sorry, someone has unmuted. Someone wants to ask anything? Okay, no problem. Neutrophilia, raised WBC count, evidence of hepatocellular liver damage, which is by the liver biochemical derangements, raised bilirubin, raised GGT. Synthetic function of liver dysfunctional, that is characterized by raised INR, low albumin. Mixed respiratory and metabolic acidosis. So these are the positive findings. Maybe you may miss some, you may add some things to this, but whatever the examiner wants, if they find you are told all these findings, they will move forward. Okay. Now, next question, usually in most of the cases, is what is the immediate management does this patient require? Immediate management question is usually because this is a critical care exam. The questions and the case is usually very much focused on the acute medicine. They will not go to the normal medicine kind of thing, that how will you maintain the sugars, how will you go for the further plan of management. The questions will be focused mostly on the critical care settings and what you will do when the patient comes to the ICU. Okay. So what will be the immediate management does this patient require? So this is one more tip what I give to my students is, usually say this line first. It will score you some good marks. Acute assessment, resuscitation and management should be undertaken to follow an airway, breathing, circulation, disability and exposure approach. Okay. The teaching in UK and the trainees, they are trained in such a way that everybody in I think someone has unmute by mistake. Can you mute yourself? It will disturb the class. If you want to ask the question, you can definitely unmute and ask any question or any doubt is there. If no questions, please unmute mute yourself. Thank you. So acute assessment, resuscitation and management as per the ABCDE approach. So the trainees over here in every ICU, whenever we take the rounds or everything, they will put a note in this pattern only. They are taught from the first year itself that every patient is to be seen in this pattern. So they expect you in exam edict 2 that you also answer for the question for the management of every patient. These things should come in the answer: airway, breathing, circulation, disability, exposure. We are taught these things in India, but usually we don't follow just a systematic. We see everything, but not in this way that you are expected to do. So I would suggest you utter this line whenever the acute management is asked. Then rest of the things in this patient, based upon the GCS and metabolic state, intubation and ventilation are required, fluid resuscitation is required, central access, invasive arterial BP monitoring is required, septic screen is required. Here in India, what we say is usually is we'll send the cultures and this kind of thing. They consider it as septic screen. If this word you utter, it would score you good marks. Septic screen, this screen should include the blood cultures, urine and an ascitic tap. Okay. How will you classify his liver condition? Now classification in this, he was a CLD patient, he has gone into decompensation, or other thing is he has gone into the acute liver failure. You can classify it, but don't need to explain each and everything. Like what are the types of classification? O grandis system classification is commonly used for ALF. Child Fluke classification, most of the students which I have taken the Viva, they have answered this correctly. Then other classification system, you should know, you don't need to know each and every detail, but if you even tell the name, that will score you good marks. Brenner's Japanese AASLD classification, this also can be used. See, don't try to go and tell the details of each and everyone. If the examiner wants, they will ask you, can you describe any one of this? Then you can describe it. Okay. Like O grand is one, hyperacute, acute, subacute. You'll get this in books. You can go and read all this. Okay. Then why is it important to classify liver failure? Very practical question, that why are you classifying this liver failure? Helps to risk stratify and prognosticate the patient. This is the reason why we classify uh, liver failure. Then what are the etiologies of ALF? Okay, so 1TP here, see, questions will come in EDIC 2 of two types. One will be exactly related to the case, like what is there in this case, and you have to answer. And few questions are there to test your knowledge. This is a general question to test your knowledge. So this is what are the related to the liver failure. They are asking you what are the etiologies. In this, you don't need to say only which is present in this, like the patient etiology in this mostly is the alcoholic. He was drinking alcohol, so alcohol is the most common cause. But you have to describe all the etiologies. So viral hepatitis related, drug related, toxins, vascular events, pregnancy, miscellaneous. What I suggest you here, whenever such question comes, their etiologies, risk factors, and these things, you divide it into separate parts, like infectious different, drugs related, toxin related, and others. That so that you don't miss anything. If you go haphazard, like alcohol, paracetamol, viral hepatitis, acute fatty liver, you are bound to miss few things. And what will happen is there are fixed marks, 3 marks or 4 marks. You have to utter those words. One or two you miss, you'll miss marks, because these are the direct questions and very simple questions. You cannot afford to miss any 1 mark also in such a questions. Okay. What is the pathophysiology of hepatic encephalopathy in ALF? Most of the people which I took, they have answered it correctly. The pathophysiology, they have answered it as ammonia. Ammonia, yeah, it's implicated in this hepatic encephalopathy, but along with that, local and systemic inflammation, along with the accumulation of neurotoxins, are implicated, and they can cause this hepatic encephalopathy in AF. Other thing is glutamine gets transported into mitochondria, where it undergoes hydrolysis to yield high levels of ammonia. This results in deleterious effects such as induction of mitochondrial permeability, transition, and oxidative, sorry, nitrative stresses. What is the role of liver protective measures such as N-acetylcysteine, branch chain amino acids, and lactuloses? This was a question. So N-acetylcysteine has got a role when administered early and can reduce the liver damage and hasten recovery in patient with acetaminophen induced ALF. Regarding branch chain amino acids and other things, they have lactulose, they have no role in acute liver failure. We give it in patients. There are different measures what we do it, but if we see it theoretically, they have no specific role in acute liver failure. Now we move on to the next minute. The patient is transferred to the ICU. A septic screen to include the ascitic tap is planned. Describe the process of carrying out an ascitic tap. So how will you do an ascitic tap for this patient? So the process, everyone knows, you all must be working in your ICU. You must be doing it very regularly. But few important points you should not miss when telling or describing the ascitic tap. This is the first thing is, you should tell, I will obtain a consent from the patient or their proxy, because I took a viva of most of the students. They missed this point. No one said, I will take a consent. This is the important part. This will carry a mark. Whenever any procedure is asked to you in the exam, always say, I will obtain a consent. It carries some mark. Okay. And rest of the things, I think you will be, most of the people have told correctly. I will position the patient correctly using an ultrasound guided, then under all aseptic precautions. I will clean and drape the patient, infiltrate the skin with lignocaine, local anesthetic, and then insert a needle, aspirate the fluid, and I will send it for tests and culture. Okay. So some liberty is given. It's not that exactly what I have written in the answer. You should be 100% writing this 20 gauge needle, 20 ml 2 takes and what this. You can say as you like, but Important things should be included which carries mark, like consent, position, aseptic precautions, uh, local infiltration, and at the last, sending the ascitic fluid for the tests and cultures. Okay. So what tests should the ascitic fluid be sent for? So you can tell a battery of tests, whatever you want: cell count, differential count, microscopy, culture, sensitivity, LDH, albumin, amylase, glucose, cytology, everything you send for that. Okay. You should utter maximum of the things, most of the things they will be included in this whole testing will be done. How would you diagnose spontaneous bacterial peritonitis on the basis of the test? You have sent all the tests. Very simple. If the polymorphonuclear cells are more than 250, we diagnose it as uh, spontaneous bacterial peritonitis. How does this differ from tuberculosis ascites? In tuberculosis, what is there is predominance of lymphocytes instead of polymorphia neutrophils. Okay, so this will differentiate it from the tubercular ascites. So next minute, the patient has an ascitic WBC of 1800, diagnosis of SBP is made, and the patient is commenced on piperacillin tazobactam. Okay. So next question is, what further investigations would you consider? See, biochemical investigations you have sent, you have done the ascitic tap of the patient. So the next thing is, patient is having SBP. What you'll do is renal biochemistry to be done, and an abdominal ultrasound is warranted at this place for this patient. You may differ with the answers. You may feel no, some other investigations you would like to do a CT scan to this patient. Some would feel they would like to do an endoscopy. There had been a bleeding and HB is low, anemia is occurring. So that's fair. I see in EDIC 2, this is total a clinical exam. It's not like EDIC 1 that out of this four, this answer is 100% correct and you have to agree. Till the thing everything is logical, you say it's all about how you are managing the patient, what you are thinking, what you are doing in your ICUs, and what pattern you follow for such a patient. So you can say a battery of investigations, because I have taken the viva. Some people have told many other. I don't say they are wrong, they are also correct, but this is what the examiner want at least. So they will go for the renal biochemistry and abdominal ultrasound. Now the next minute, the patient has an abdominal ultrasound. It reveals liver with severe cirrhosis, no evidence of hepatocellular carcinoma or portal vein thrombosis. Kidneys appear normal. Patient has a baseline creatinine of 74, which is now to 20. Patient's vasopressor requirements continue to increase. The acidosis continues to worsen. Okay. So the next question is, what are the likely causes of this acute kidney injury? Okay. So the answer is the three causes. It can be pre-renal due to the hypoperfusion, the sepsis was there, cardiac failure, hepatic failure, intrinsic renal nephrotoxic drugs, post-renal renal flow outflow obstructions, and the last one most likely in this case it would be hepatorenal syndrome. Now, uh, one thing I just wanted to tell you in such a question is, what used to happen in previous exam was like, what are the likely causes of acute kidney injury? So they are expecting in this patient is having hepatorenal syndrome. So if you don't answer hepatorenal syndrome as one of the causes of acute kidney injury in this patient, there was a note for the examiners: if the candidate does not answer hepatorenal syndrome, don't proceed with the questions of hepatorenal syndrome. So what would happen previously was, when we gave the exam at that time, they till you tell hepatorenal syndrome, they will skip few questions because you haven't uttered the thing. But the good thing with EDIC is now is they have deleted these things. So even if you will not utter hepatorenal syndrome in this case, because the further viva would be on hepatorenal syndrome, the examiner will tell you this is hepatorenal syndrome, and then he will continue with the viva. He will not give you a mark for this question, but he will himself tell you that this is hepatorenal syndrome and proceed the viva further. So they have made it a bit easy and you don't lose out on the questions. So what are the diagnostic criteria for hepatorenal syndrome? Very important topic, hepatorenal syndrome in you can get in any of the cases somewhere. Okay. So recent hepatorenal syndromes, they have given the criteria HRS AKI, that is the acute kidney injury, and non-acute kidney injury. They have divided again into HRS acute kidney disease and HRS of chronic kidney disease. The criteria you can go and read, you'll get anywhere in the net, and just be thorough with these things. So how will you manage hepatorenal syndrome? A very uh, simple question. You'll get the management of hepatorenal syndrome in each and every book. Most of you answered this very correctly. So vasoconstrictors and albumin like terlipressin, midodrine, or norepinephrine. Tips can be done if not responding, if not renal replacement therapy. And the last resort in hepatorenal syndrome, if not responding, is the liver transplantation. It's a it's a difficult for me to in this 1 hour to complete each and everything. So I'll just tell you the salient points. You can go and read the complete details of hepatorenal syndrome. It's available everywhere in each and every book and in the on the internet also. Okay. What are the characteristics of patient with acute liver failure? Just one thing I wanted to ask each one. Am I very fast? Are you able to catch up with me? You are able to understand what I'm trying to say?
Yes, sir.
Everybody? If
Yeah, yeah.
Yes,
if
yes,
at any point you feel, because what I feel is I'm a bit quick. I say things very fast. So if at any point you feel you're not able to catch up, you can unmute and just tell. I'll slow down with the things. Okay. At any point in some question you feel you're not able to understand, you can definitely unmute and ask for an explanation. Okay.
Yes,
If
sir.
you're not unmuting, I feel everybody is there and they are able to listen to me and they're understanding what I'm trying to say. My purpose in this debriefing is not to teach you acute liver failure. You can go and read it in hundred of books, you will get everywhere. The important thing is you should know the pattern of the exam, what is expected. What I tell my students usually is like in cricket, I'm a big fan of cricket. Na? Before playing the game, you should know the pitch, in what pitch you are playing. You can plan accordingly. Most of the people fail in EDIC not because of their knowledge. You have a top class knowledge of critical care, you know each and everything, but you don't know the pattern. The EDIC pattern is quite different. What is expected from you, you have to answer accordingly. That is the main purpose of this debriefing I'm trying to tell you. Okay. So question is, what are the characteristics of
Sir,
the patient? Yeah,
one question, sir.
please.
So,
Yeah.
sir, if they ask some
Hmm,
etiology
hmm,
or some
hmm,
characteristics, and
hmm,
if they have marked almost like six or five or six
hmm,
things they have
hmm.
marked, and if you have
Yeah.
spoken about two or three, you will get the mark, or you
Yeah,
don't.
yeah, definitely. Yeah, this one more thing, good thing you are told. See, previous years from 2000, before 16 or 17, I think they had a system of marking that was there was a uh, uh, answer which was they were marked as per their priorities. Like in this question, just I'll try to tell you. Like this question was there. In previous exams, the marking system was if four answers are there: pre-renal, intrinsic renal, post-renal, and hepatorenal. But the most probable in this was hepatorenal. So if you tell hepatorenal syndrome, you will get 5 marks. For post-renal, intrarenal, two marks, and pre-renal 1 mark. So the marking was given separate for each and every answer. Like in etiology, in this patient, the patient etiology was alcoholic. If you will tell alcoholic, 5 marks, then others will carry 2 marks, 3 marks, and which is the least probability will get 1 mark. But due to this system, many of the candidates failed, and they had created objection on the system that we have told few answers. But we are still failing. We are getting less marks. So EDIC has deleted the system. The system now is each and every answer will carry 1 mark. So in this question, even hepatorenal syndrome is the most probable answer in this question. But even if you answer pre-renal, intrinsic renal, and post-renal and miss the most important diagnosis, you will get 3 marks out of 4. You understood the pattern now is. So DDs or the etiologies, whatever you say, each one carries 1 mark. So it's an equal distribution of marking, what I say nowadays. And previously, it was the most probable answer carried the maximum marks, some less probability carried some less marks, and the least probable answer carried the least marks. It was that system. Now that is gone. The marking system has changed. A lot of things have changed in EDIC2. I think you all should go and see on the ESICM site in the education system in EDIC2. They have given the everything, they have given how the marking, how the exam goes. You should be thorough with that. Okay. So where we were, I think it's already 1 hour. I should be quick because I have to complete the CBS also. Okay. What are the characteristics of the patients with acute liver failure which warrant liver transplantation? Characteristics, what they are asking you are the criteria for the liver transplant. So very famous King's College criteria, paracetamol induced, non-paracetamol induced, pH criterias and other criterias. I'll not go into the detail. You can read it from your book. It's the King's College criteria. What alternate criteria are for the risk prognostication in acute liver failure? So alternate criterias, there are many given. Clinch's criteria, MELD score, modified MELD score, you can get in the books. Don't try to explain them, just say the names. If the examiner wants that explanation, what is there in that, so they will specifically ask you, only then say. Okay, you can say that only the names of the criteria. Are there any specific disease oriented therapies in acute liver failure? Most of the students which I took Viva, they answered it correctly. Like in pregnancy, you can go for termination of pregnancy, antivirals in cases of viral hepatitis, anti-neoplastic medications in case of carcinoma. Tips can be done in Bacchiari and without renal failure and encephalopathy. And for this mushroom toxicity, you can go for penicillin G or silibinin. So these are the specific therapies for a few of the causes of acute liver failure. So what is the role of steroids in LF? Multiple answers I got. It is very controversial kind of thing. Few people will say there is a role, but as per the guidelines, as per what we practice over here, the steroids have got no role in acute liver. We'll move on quickly with the CBS. Okay. So in CBS, what I say to the students is important tip is it is like a T20 game. It's race against time. You have to be very quick. You have to answer the question quickly, because if you spend much more time on some difficult question, you may miss the easy questions will be coming further. Good thing about CBS is if you don't know, please say pass. You pass on the question, or you say, sir, next question, please. So that they move on. And if you have got time in at last, they can come back to the questions you have not answered. One more tip is, few people think that I have answered that wrongly, so they can come back. They don't come back. If you have answered it, they will not come back on it. Only to the questions which you have not answered, they will come back on that questions. Okay. So first of all, the curves, the first is this: list 3 measures which are used in the management of the condition indicated by the following ECG. I took 5 of 3 people. I think all the 3 have answered this correctly. This is very typical ECG. I have kept a very simple one. You can see the Osborne waves. This is a hypothermia kind of ECG. But the question, you should read it correctly. Question, they have not asked you what kind of ECG or explain the ECG. List 3 measures which are used for its management. So from the ECG, you interpret this is Osborne waves, this is hypothermia, and you have to tell 3 measures to correct the hypothermia. Do not go and explain the ECG. Please, this is my sincere advice. Most of the students do it. They will start from the what teaching. The axis is okay. Now the what is the P wave, then the QRS, then the what is the ST, then what is the T wave inversion is there, then the Osborne wave is there. So now this is this will waste time. Focus on what is asked. You can say, definitely, I don't say that you should say there is an Osborne wave. I feel this is a ECG of hypothermia, and list 3 measures for hypothermia. Okay. So hypothermia, warm blankets, IV fluids, warm humidified oxygens. This is mostly, and this is the explanation for that, what they have given. Rational, I can tell you, this is a sinus bradycardia, 60 beats per minute. Normal axis prominent J waves, Osborn waves, which indicate severe hypothermia. Widening QRS complexes predominantly due to the J waves. Widening QT interval, the PR segment is often prolonged in hypothermia, but not in this case. Can you see this? These are the Osborn waves, which indicates hypothermia. So next question was, you'll always get few questions on ECG, 4 to 5 ECGs, one ventilator graphic. So this is a ventilator graphic question. This patient is being ventilated with a FiO2 of 0.9. What type of pulmonary deficit is suggested by the ventilator waveform displayed below? List the causes of this pattern of pulmonary deficit. They've given you this ventilator waveform. ETCO2 trace is also there, which has been given. Values are also given. If you can see it very clearly. On the x-axis, the time is there, and the y-axis, the values are also given. So you have to interpret what kind of a pulmonary deficit is going on in this ventilation, and what are the causes of it. So if you can see it clearly, this is a poor pulmonary compliance during PCV with hypercapnia, suggesting impaired gas exchange. And the cause, mostly, this is a ARDS kind of ventilation. If you can see, the I ratio is 1:1. Permissive hypercapnia is there. Patient is being ventilated on 0.9 of FiO2. That means his oxygen requirements are very high. This is a typical ventilator graphic for a patient who is being ventilated for ARDS. So causes of ARDS: sepsis, aspiration, inhalation, fat embolism, amniotic fluid, pancreatic induced intratracheal. So many causes of ARDS. So the what you can see in this thing is, if you see it clearly, the inspiratory pressures are 35, PP is 20, pressure support is 10, tidal volume, if you can see in the volume, it's just 300 ml going on. So this is actually a low tidal volume ventilation what is going on, and the I ratio is kept as 1:1. If you can see in the ETCO2 trace, the I ratio is 1:1. So this is a ARDS kind of ventilation which is going on with permissive hypercapnia in cases of refractory hypoxia. Okay. Next, comment on the arterial line. What test will you confirm for this finding? What are the common causes of the waveforms in the ICU? Most of you got this correct. This is a dampened waveform of arterial and overdamped arterial waveform. What test you will do is the fast flush test. And what are the causes of it? Air bubble, clot, overtly compliant tubing, kink tubing, stopcocks, low flush pressures, impregnated against the vessel wall. So very simple and direct question. I'll not go into the detail. It's a overdamped arterial waveform, and the test name is fast flush test. You can also tell it as square wave test also. Some of the people, examiners, would want this answer, square wave test. So fast flush test, square wave test. And causes you all must be knowing. Next, identify the image. What is the advantage of this technique? A tough kind of question. Usually it doesn't come, but still I have kept it just for your practice. So what is going on exactly in this is called an electrical impedance tomography, which shows regional ventilation. Very latest technique, what is done, it's for regional ventilation. The advantages of this are non-invasive nature that allows continuous monitoring of the lung ventilation in both mechanically and spontaneously ventilated. What it does is, it's a tool for the therapeutic intervention, such as optimizing the PEEP. Once you get the findings, if the PEEP is not optimal, you can optimize the PEEP to assess the efficacy of the recruitment, to diagnose the mainstem intubation and pneumothorax, etc. Out of the 10 curves you will get, one or two will be a tricky ones like this. So that will be at the last. So if you answer previous one correctly, you go up to there, you can get them correctly if possible. So you go and read this. I don't feel this would exactly come in the exam, but a tough one, I have kept one on this. Okay. So comment on the report of post-operative patient with persistently high drains for the past hour. See, this is a TEG waveform. Most of you have read this. TEG is a very common curves. You can get an image of a TEG. What usually you will see in these values given over here are R time, K time, the maximum amplitude, everything seems to be almost normal. What you should concentrate in this tag is this is a post-operative patient and having high drains for the past 1 hour. Some clues are always there in the history what they have given, not only in the image. And the R time a bit raised. Okay, this is the only thing what you get. Rest all the things are within the normal. So this patient has almost normal tech except mildly deranged R time. It is unlikely to explain the clinical scenario, and surgical cause for the bleeding should be actively sought. So the clue was in the history what was given. This is a post-operative patient with high drains. So most probably what has happened in this patient is there is no abnormality in the platelets, no abnormality in the coagulation factors. The problem over is the surgeon has left some bleeder and the patient is bleeding due to that. So cannot explain the high amount of bleeding with these values. So it is most probably a post-operative bleeding due to some bleeder. Okay. Rest, I'll not go into the detail of tag. You can read the tag in each and every book and net ULA. What is R time? What is K time? What is alpha angle? What is mean amplitude? What is LY 30, LY 60? And what are if they are raised, what you need to give. Okay. Next, comment on the red form shown in the monitor. What are the hemodynamic changes that occur with augmentation? How do you time the augmentation? Very typical, very high likely IABP. IABP is one of the favorite topics of EDIC people. You may get such IABP question in the CBS also. This can come in cases of in Viva also, that what next you will do. The patient is not maintaining blood pressure and patient is deteriorating, what support you'll give. So IABP can be discussed in that also and here also. So this is a very typical trace of IABP. So what hemodynamic changes are there with augmentation and how do you time the augmentation was the question over here. Most of you told this correctly. It is an IABP augmented 1:1 augmentation is going on in this case. So what I would not go into the detail of this. You can read IABP. The most important things what I tell you regarding IABP is whenever you utter about IABP, they have asked the question. Always tell them that it's 1:1 or 1:2, whatever it is. Other thing is only four things are there in this: early inflation, late inflation, early deflation, late deflation. Just go and see the images of this in Google Images. Just Google Images, you type IBP, they will give you the images. Just keep that picture in mind so that as soon as you see such a trace, you will be able to diagnose whether it is early inflation, late inflation, early deflation, late deflation, and you are able to diagnose it very correctly. Also, I have not kept one trace for the ETCO2. ETCO2 is also a very important topic. You just go in Google Images, track ETCO2 traces, you will get complete images. Just go and by heart what shark fin, in which cases it is in esophageal intubation, what curve you get. That is also a very important topic. Okay. Next images. I think I'm running quite late. It's already 1 hour 15 minutes. Should I continue? Are you bored up? Should I continue or take another class for this afterwards, or should I finish this?
We can finish. For me,
Huh? Yeah, because
Yes, sir, please
more than
continue.
1 hour it's it is difficult to concentrate. I'll try to finish it as soon as possible. Okay. So images, young lady crossing a busy road when she was hit by a car, injury or the severe traumatic brain injury, CT scan following 24 hours into the ICU admission shows ICP is 30. Especially they have given the value of the ICP. List your possible management strategies. So another tip, they are not asking you to describe the CT scan. Like people, as soon as they say that, they don't read it. This is a CT scan of the head. It is showing hemorrhagic contusions. Then it is showing loss of gray white matter differentiation, cerebral. They have already said that cerebral edema, the ICP is 30. What are the possible management strategies? The possible management strategies, It is CT of hemorrhagic contusion with right temporal lobe. Her management is divided into medical, surgical, others. Medical is all the neuroprotective strategies for raised ICP. Midline head position, which do not obstruct the venous drainage. Sedation, CO2 within normal range. Osmotherapy with mannitol and hypertonic saline. Surgical, you can go for decompressive craniotomy. Other management strategies, seizure control with midazolam initially and then with phenytoin or Levipil. Neuromuscular paralysis, therapeutic hypothermia, thiopenton coma. So all the measures to decrease the intracranial pressure you can tell in this patient. What is the most common cause of the principal abnormality seen in this scan? So another CT scan I have kept in this case. If you can see it clearly over here, there is some white dots over it. This is the pancreatic area. What has occurred in this calcification of the pancreas? Most of you got this correctly. So calcification usually seen, it is in the chronic pancreatitis. So it's chronic alcoholic pancreatitis. The pancreas is speckled with calcification, which is most commonly associated with chronic alcoholic pancreatitis. There is also free fluid around the liver, diffuse mesenteric fat standing, secondary to inflammation. Okay. So another question, this is just a minute. Okay. So 69-year-old patient started on CVVHD following admission through ED with acute on CRF. The patient has been hypotensive, tachycardic since admission, despite several intravenous fluid boluses. There is no fever. Patient is mildly confused. Echo is performed, trying to clarify the cause of hypotension. Subcostal view images is shown below. Demonstrate 3 possible causes of this patient. So this is a echo image subcostal they have shown you, and if you can see this clearly, there is a thin rim over here. Okay, if you know. So one thing I want to tell you, in echo and all, you're not a cardiologist. They also know that. So, and in ultrasound also, they will not go into the very detail. You'll get very typical images which you can diagnose. So don't worry. Don't think that you will get a very difficult image or very difficult video they will show and expect you to be a cardiologist or a radiologist to diagnose that. So very simple images will be there. So you can diagnose. You can see there is a pericardial effusion in this case, and the history what is given, that will have some clue to take you towards the diagnosis. Like this is a CKD patient with a large amount of fluid has already been given to the patient, so the patient is in fluid overload. So that is why you can consider that this can be a pericardial effusion. So it's a moderate pericardial effusion. Causes can be uremic, nephrotic syndrome, hemorrhagic pericarditis. Still image shows typical subcostal view of heart with right ventricular closest to the probe, separated by tricuspid valve. Yellow arrow in image is pointing to the moderate band that runs across the image. The heart is surrounded by a rim of free fluid, that is a pericardial effusion. Can you see the pink arrows? This is the fluid which is the pericardial effusion. This is the right atrium, right ventricle, left atrium, left ventricle. Okay. So one more a bit of tough one, but most of you got this correctly. This is a 36-year-old lady, day 5 of admission in the ICU following collapse, fissure grade 3, subarachnoid hemorrhage. Level of consciousness deteriorated, withdrawing from central noxious stimulus to extension to the same stimulus. The pupil is equal, reactive to light. EVD does not appear to increased in the output rate. Okay, the patient is not bleeding. The following investigation is performed. What is this investigation? What does it demonstrate? And list 3 management options. I put 3 questions. Usually there are not 3 questions. 1 or 2 questions will be there. To explain this, I put 3 questions in this. So what is this? Everybody got it correctly. This is a TCD. There is a transcranial Doppler is going on of the middle cerebral artery. And here is about the carotid artery. So this is a transcranial Doppler study of the right MCA, and image B is the right internal carotid artery. So 2 images were shown. This is of the middle cerebral artery. Here it is written MCAR. That means it is the middle cerebral artery of the right side. The trace is there. Here it is carotid. Okay, the second trace is of carotid. So why both are done? Moderate cerebral artery vasospasm in the right MCA with a Lingard ratio of 5. What to do? Ensure the patient is receiving nimodipine, radiologically guided intraarterial verapamil can be given, or percutaneous angioplasty given. This is the treatment for vasospasm, what has occurred in this patient. Rational, this is the mean MCA velocity is 178, suggests mild to moderate vasospasm. The maximum MCA velocity divided by the peak ICA velocity yields the Lingard ratio. Okay. So this is the image what I had shown. This is, you can, if you can see there, it is written right MCA. This is the mean velocity. This is the maximum velocity. This is for the carotid and its velocity is 51. So we divide it by this, you'll get the Lingard ratio. This patient presented with dyspnea, required intubation for respiratory distress. Intubation was difficult. Identify the cause of the events. I think one of my candidate got this correctly. So if you can see, there's a mediastinal widening over here, and this was the cause of the difficult intubation in this patient. So there is an abnormal upper mediastinal soft tissue opacity. The ETT appears to be deviated to the patient's left. The lung fields do not show a gross pathology to explain the dyspnea. Heart is normal. Tracheal compression from a mass lesion is a likely cause of this problem. Subsequent CT also revealed a large retrosternal goiter. You can see this was the mediastinal widening, and when the CT for this patient was done, this was the large retrosternal goiter, which has caused difficult intubation due to the airway collapse. Okay. So identify the image. What is the clinical usage? Yeah, most of you have got this image correctly. So this is a ONSD. It is optic nerve sheath diameter. What is optic nerve sheath diameter? It is measured 3 mm from the eyeball, normal values of 4.8 to 5.9. It it is prone to inter-observer variability, but still can be utilized as a reliable bedside measurement of the intracranial hypertension than clinical judgment, especially in patient having altered sensorium or under sedation. Okay, you can see the image again. This is typical of optic nerve sheath diameter calculation. It gives us an approximate image of what is the intracranial pressure is there. Is there any intracranial hypertension or raised IC? Okay. Now move on to the most difficult, that is the biochemistry part. Let's see, I'll show you 5 questions of this also. So the first question was, this is a 59-year-old lady in the ward recently treated with active rheumatoid arthritis awaiting completion on her discharge plan. A MET call was put for a witnessed collapse that occurred when she got up to use the bathroom. The first intravenous bolus has not improved her blood pressure. What therapy would you consider next? So this is a patient. She has rheumatoid arthritis awaiting discharge, suddenly collapsed in the ward. Fluid bolus was given, but that did not improve the BP. The values they have given is urea is 11.2, creatinine is 91, sodium 127, potassium 5.9, chloride 96, TCO2 21, the calcium is 2.3, magnesium 0.87, phosphorus 1, albumin, blood sugar is 4.1, osmolarity is 273, urine osmolarity is 315, urinary sodium is 47, urinary chloride is 21. So when you see so many values, you get confused. You have just 1 minute. It's the most difficult part what occurs in biochemistry questions. You are unable to even interpret, see the and read the values, and the 1 minute is over. So tip from my side is, the first, the good thing. The good thing now is I haven't given the values in both the units, but now EDIC people give values in both units. So you don't need to worry that creatinine is given in micromole, so you are not able to interpret how much is the creatinine. They will give in both the units, so you will be able to interpret. The second good thing what has occurred with EDIC is nowadays, in since few years, every abnormal value will be marked in red. So what you do is, when you read the question, and don't read what values are given in black. Read only the values which are given in red, and try to interpret and give the answer to the question. That would help you to solve that question correctly in biochemistry, because biochemistry, I think, is the toughest part most of the students feel, because you have to interpret and the long question will be there. The time is very short. If you are given, if we I give you 5 minutes or 10 minutes to solve this, you will definitely able to solve. You have read everything, your knowledge is very good. But the important thing is, within a minute you have to read the question, interpret the investigations what are given, and give an answer to this. So both units, the value is there and it is in red. Read the values which are only abnormal and try to answer the question. Okay, so in this case what is occurring is, the patient was on rheumatoid arthritis, the steroid withdrawal has occurred. That is why the patient's BP is not improving despite the fluid boluses. How you can interpret that is, this is a case of Addinsonism secondary to acute steroid withdrawal. Recent steroid therapy implied by the management of active painful rheumatoid arthritis, postural hypotension episode, and the blood pressure not responding as expected to the volume challenge is consistent with adrenal insufficiency, as is the hypoosmolar hyponatremia. Can you see the hypoosmolar hyponatremia was there with elevated potassium and urinary sodium more than 20, low blood glucose, and normal anionic gap metabolic acidosis. TCO2, you can consider this. TCO2 is written in every question. Usually they give this value. It's surrogate of bicarb. It's total carbon dioxide is surrogate of bicarb. You should consider that is the bicarb value. Okay. And what therapy you will give for this Addisonian? 100 milligram hydrocortisone IV or 4 milligram Dexa IV, and to reinstate a regular oral dose of prednisone. This is the steroid deficiency what has caused this. It was indicated by hypoosmolar hyponatremia and elevated potassium. What I feel is, whenever you practice for biochemistry, just try to develop a pattern in your mind. Like whenever you see hypoosmolar hyponatremia with elevated potassium, it can be Addisonian, so that in actual exam you are able to some clue you get from the pattern. I'm not saying always it will be correct, but some clue you get from the pattern if you have practiced a lot. Next, this is a 48-year-old gentleman
Sir,
got to the emergency. Yeah.
Sir, in last question, like we have given the patient fluid boluses, but it's
Hmm,
refractory and not increasing.
hmm, hmm,
So, what
hmm,
therapy would you, sir? So,
hmm.
what if we say that we starts on vasopressors for that
Yeah,
patient?
yeah, yeah.
So the answer is
This
right
can
that
come.
we have to look for the cause of that reason.
Yeah, yeah,
The
yeah.
next therapy, what immediate is warranted is like the patient. We will start with vasopressors, right?
Hemraj, correct, exactly correct. You said some of you have answered, and I would have also answered this as vasopressor, because the fluid, the patient is not responding. Other thing, what you see is, you don't see only the history. If you can see what values are given, what is occurring, you have to find some clue in the values which are. If no values are given, only this history is given, what would be your next step? It would be obviously vasopressor. The patient is not responding to the fluid, but you have to find what is the cause of this hypertension. That has been given in the values which are there. The hypoosmolar hyponatremia is there in the patient, which was a patient of rheumatoid arthritis. So you have to interpret it in such a way, the patient should have been on steroids on rheumatoid arthritis, and it's the acute withdrawal of steroid which can cause this. Things means it appears to be a bit difficult, but this is what how the biochemistry questions come. Okay, I'm not saying you are absolutely wrong, but you have to consider what question is being asked and what values are given and how do you interpret those values. The biochemistry questions are about interpretation of the values and finding a diagnosis and the treatment for that condition. Mostly it's this way. It's not a typical clinical question, that if this question would have come in a case in a CCS, what immediate management would you do? Patient is not responding to the IV fluid boluses. I would have answered it as, I will start noradrenaline, a vasopressor for this patient not responding to the fluid boluses. But with the context of this CBS table viva, with the values given over here and the history what they have given of rheumatoid arthritis, you have to interpret in that. Okay.
Yeah. Okay, sir.
Examiner would respond anything else.
Sorry?
The examiner would respond anything else. So then we'll have to say anyways.
Yeah, you can. This I told you, na, all the examiners are given instructions that if you are wrong, they will give you a prompt. They will give you one time they prompt usually that anything more can you think of? Okay, so you can think of anything else if you feel that, so this is not the correct answer. Okay. Okay. Moving on, this is 48-year-old gentleman brought to the emergency department by ambulance, found in a park land, confused. His observations are as follows: heart rate is 107, BP is 98 by 56, respiratory rate 26, saturation is 94% on room air, temperature is 35. What further test would you request? So few values are given. Urea is 11, creatinine 109, sodium is low 129, potassium is high 5.6, chloride is low, TCO2 16, BSL 4.3, the sugars are low. Osmolarity is 298, okay. Urine osmolarity 387, okay. The urinary sodium is 8, calcium is 2. There are many values given in this. Few of the values will not be of any use. They are give these values just to waste your time. Okay. So what my tip was, in first, just see the red values what are there. I have not given this. This is just a mock test to make it a bit tougher for you. Okay. Calcium is 2.05, magnesium is 0.72, phosphorus is 1.35, albumin is 3, and uric acid is 0.52. So usually if you read many questions of biochemistry from the books, you get such a scenario. One of the question will be in this scenario: the patient parkland or somewhere in the garden, he's confused and found unconscious. So 2 or 3 DDs are usually there in these questions. Your mind should interpret this question as one of this will be there in such question, because the see pattern of the questions will be almost the same. They cannot change so much questions and do so much things. If you read the previous question papers of biochemistry, you should have a clue with the from the history itself. So in this case, what is happening is this patient has got alcohol toxicity. He is alcoholic, and what test you will require: serum ethanol and methanol level. Why? See, this is a young to middle-aged adult found with altered consciousness in a park, usually suggesting trauma or toxicology. There was no history of trauma in this case. A hyperosmolar hyponatremia with a wide osmolar gap and acute renal impairment due to the prerenal deficit is consistent with alcohol toxicity. Raised anionic gap metabolic acidosis is due to the products of alcohol metabolism and acute renal failure. Hypoglycemia may be an acute alcohol effect. Hypoglycemia, you should consider very important factor. Hypoglycemia is seen in this alcoholism, or in addition with the low albumin, may affect malnutrition due to chronic alcoholism. So low albumin, low glucose with hyperosmolar hyponatremia, and with the context of the history, patient found confused in a park without any trauma, it points towards the alcohol toxicity. Okay, we'll go on to the next one. This is a 34-year-old lady admitted with fever, altered behavior, decreased consciousness, necessitating invasive airway support, noted to have a urine output consistently greater than 150. Lumbar puncture was performed and the result along the biochemistry is displayed. What is her diagnosis? So very typical question. Most of you should get this correctly. I think 2 of them got correctly in my viva. Once you see a high urine output 150 ml per hour, few things should come in your mind with the history itself, what it can be. And then you can interpret it from the results what are given. Urea is 13, creatinine 125, sodium is high. So hypernatremia with large urine output, something should come in your mind. Potassium is 3.8, chloride is 118, TCO2 23, osmolarity is 319. So serum osmolarity is high in hypernatremia with urine osmolarity of 236. And other in lumbar puncture, they have shown microscopy, the RBC is 3, polymorphs 32. These are doesn't matter much. So with this 4 values itself from first, you can, I think, and the history what is given, you can interpret and tell the diagnosis. So what was the diagnosis in this?
Sir, will
Anyone?
sodium be high?
Insipidus, central diabetes.
Yeah. I think quite clear. It's a quite of direct and simple question in this. So this is central diabetes insipidus secondary to viral encephalitis. So fever with altered behavior and a rapid decline in consciousness is suggestive of infective encephalitis, usually viral. The LP biochemistry and cell count are supportive to the viral picture. Hyperosmolar hypernatremia with inappropriately hypoosmolar urine, typical of diabetes insipidus. Setting of intracranial pathology directs you to cranial diabetes insipidus. Additionally, elevated serum uric acid also supports cranial over nephrogenic diabetes insipidus. The pre-renal urea to creatinine ratio and raised serum albumin suggest intravascular volume deficit consistent with the main diagnosis. So this was central diabetes insipidus. You should interpret and some DDs should come in your mind with the history itself. And biochemistry, you feel it is difficult, but when you start recognizing the pattern of questions, I think without seeing the values also, some DD comes to your mind, you can answer this question. Okay.
Will urine sodium be high, sir? 74, I saw. And urine
Urinary
osmolarity.
osmolarity is 236.
Okay.
Okay. So next we'll move on forward. This is a 25-year-old gentleman admitted to the ICU, heavily sedated, intubated, ventilated, following fall from a construction scaffolding. He sustained rib fracture, significant head injury, returned from operating theatre after decompressive craniotomy was performed. What is your explanation for this initial blood picture? A bit of tough one, but let's see if you can get this. Urea is 7.3, creatinine 87, sodium 151, potassium is low 2.6, chloride is 116, TCO2 26, sugars are 8.1, okay, osmolarity is 334, urinary osmolarity is okay 417, urinary sodium is 32, calcium is 2.25, magnesium 0.87, phosphorus is 0.96, albumin is 32. Anyone?
Intraoperative 3% NaCl.
Yeah. One of them can be, it can be 3%. It can
Mannitol
be
also.
mannitol.
Mannitol also.
Any hyperosmolar therapy has been given to this patient. Excellent. So recent mannitol therapy can be 3% NS also. Any hyperosmolar therapy had been given to the patient. This can cause this picture. It's a traumatic brain injury with management suggesting there have been difficulties in management with ICP. Hyperosmolar hypernatremia with widened osmolar gap consistent with recent mannitol therapy. Hypokalemia suggests that the sedating agent may be thiopid. Okay, very good. So your registrar has just received an oncology patient who is started on chemotherapy. This is a very typical biochemistry question. Just learn this question. You can expect this question. Okay. For a large abdominal high-grade non-Hodgkin's lymphoma, the patient has been oliguric for several hours. A lot of values are given over here. The important thing I'll tell you, urea is 24, creatinine is also high, sodium is bit high, potassium is high, sugar is high. Then I'll just tell you calcium is a bit low. So can you interpret with these values only? No need to
ELS,
see.
sir. Tumor lysis.
Yeah, very typical biochemistry question. You should learn by heart with the history itself. Many people don't read the values also and tell the tumor lysis syndrome. Okay, very typical. This was a simple one. So this typical of tumor lysis syndrome. High grade lymphoma, leukemia with high WBC count with increased risk of tumor lysis syndrome. So what we have seen in this is raised potassium, phosphorus, LDH, uric acid support the diagnosis. The hyperkalemia is in excess of what is expected for the acidosis. Potassium rises by 0.5 every fall in pH of 0.1. Low calcium despite a metabolic acidosis has a limited differential including tumor lysis syndrome and rhabdomyolysis. The widened anionic gap is due to the release of intracellular acids from lysed cells and contributes to hyperkalemia and hyperuricemia. You can read this tumor lysis syndrome, very important topic. It can come such in biochemistry, and you can also get this tumor lysis syndrome in your case also. case also you can get. They can take you to tumor lysis syndrome. A patient of oncology came to us and this and that. Okay, very typical question. So it's a bit tough one. I've just kept this. I don't feel this will come, but for few people who want to score some heavy marks. Your registrar is concerned about a patient in the unit who is provided to wean, difficult to wean from the ventilatory support. The patient has multiple small bowel fistula following an open necrosectomy and several revisions for significant necrotizing pancreatitis, and the surgeons have requested that TPN be continued for 2 to 3 more weeks. Pancreatitis has been settled for some time and all inflammatory markers have returned to normal. Drain outputs are negligible. Patient has tracheostomy and remains on pressure support ventilation. There are no vasopressors requirement and urinary output is satisfactory. Patient is on insulin infusion of 12 units per hour. Patient is on no antibiotic, has a clear chest X-ray and clear urine microscopy. Respiratory rate is 32, saturation 98%, heart rate 110, BP is 128, temperature is 38.3, that is hyperthermia. You are shown the recent blood results. What is your response? Okay. Patient of open necrosectomy with
Overfeeding.
pancreatitis with TPN. I think you got that correct, but the history will give you a clue. History will give you a clue because in biochemistry you feel it is tough, but what happens is there are 15-20 diagnoses actually. The whole viva moves around these 15-20 diagnoses. If you know the clues and you know how to interpret it from the history itself, history will give you a very important clue before the results. So this is, he has already disclosed the diagnosis, an overfeeding syndrome. Many values are given. You can go through the values. I'll show you the explanation.
ICO2.
It's an overfeeding syndrome. Decrease the TPN rate and adjust the contents and the proportions to mean the patient's nutritional needs. Just a minute, I'm coming. Now, I'm in a meeting. I'll talk in 5 minutes. No, you can. Sorry for that. This is an overfeeding syndrome. So response is to decrease the TPN rate and adjust the contents and proportions to meet the patient's nutritional needs as appropriately. Rationale here, how could we come to the diagnosis? See, the patient is in the weaning phase and the acute pathology has settled. Therefore, complications of therapy must be considered when evaluating new problems. Despite a lack of active pancreatic markers and no apparent infection source, the patient remains tachypneic, tachycardic, hyperthermic. Hyperthermia is a very important clue in the overfeeding one. This is due to the increased metabolic state from the excess nutritional supply. The excess nutrition results in hyperglycemia, hyperlipidemia, mildly deranged LFTs, electrolyte disturbances, along with increased CO2 productions. Patient with overfeeding syndrome may also display delirium, peripheral edema, excess weight gain. Okay, so this was overfeeding. You also go and read. I had limited so that I could not. Refeeding syndrome is very commonly asked. Overfeeding syndrome, refeeding syndrome, then bulimia nervosa. These questions can come in biochemistry. If you read the typical history, you will be able to answer such questions. Okay. So that's the end of it. Just few last tips I want to tell about EDIC2 preparation. Few books I would recommend. This is a very important book, Case-Based Review by Dr. Atul Kulkarni, second edition had come a year or two back. Gives very nice viva preparation. You can read it for EDIC2. Objective Structured Clinical Examination in Intensive Care Medicine. Very nice book. You can read this for cases and all, also for the table vivas. Then I would suggest you go to the packed modules. Now they have been named as ACE modules. In each of these modules, you will have access. In the last, you will get case-based scenarios. Okay, you go to that case-based scenarios and solve them. They are very nicely given. They're given by ESICM and the Viva goes exactly what it is shown in this case-based scenarios. Go into the ESICM site, into the education. into the ACE modules, there are around 50 modules. I don't say you go for each and every one, but the important one, acute ischemic stroke, pancreatitis, ARDS, COPD, you go and just don't read the whole modules. It's very difficult. Go and solve the case-based scenarios given at the last of each of the module. That will you can have practice how the case goes. It is exactly in the same pattern. Okay. Last few tips. Use the 30 minutes at the beginning wisely, make notes, think about the potential questions. First question often is summarize the case. What is your differential diagnosis? Okay. Use a structured approach, but get straight to the point. Focus on the question in hand. If time at the end use, it will review the next weeknet. Remember, this is a European exam. Try to answer as per here, not from here. Like you get some X-rays. Don't think of too much tuberculosis or kind of things or kind of typical infections what we get in India. It's a European. Think about the diseases and the things what we get, because in EDIC, whatever case is there or the table viva, the slides they are showing or biochemistry, these are of the original patients. It is not man-made or they are not just virtual kind of thing. These are the typical patients what we get here, and that is itself kept in the viva. Okay. Focus on the logical standard management. You would do it your daily practice. For practice, try to start presenting cases in the ICU and discuss the cases in English, because fluency of English is very important in Viva. What happens, we know most of the things, but we are unable to speak out. I've seen many people, they have very good knowledge, but unable to speak in the Viva in English with the person, and they get failed. Okay. This all I have already told you. I think the last line is important. See, after the case is over, 5 minutes, both the examiner agrees on which points to give and actual markings, and this will include a general performance score for this candidate. Most of you don't know, but this is only for the examiners. When your Viva is over, if you're borderline also, in some case you're just failing in a mark or two, and the both examiners feel that no, this candidate is okay, even if technically speaking he is failing, there is called a general performance score which is given, which is in hands of the examiner. If the examiner is impressed by your viva, even if you're just failing, they can give you some extra marks from their side and pass you. It's not that you should, I feel you should pass yourself, but if such a thing occurs, so you in your viva you should impress the examiner. The way to impress is, I think, whenever you answer some questions, try to quote some studies related to that, even if it is not asked. Like if something is there in ARDS, you can just say, I will prone the patient as there is a mortality benefit shown by the ProSeva trial. You can just quote some studies. It gets a very good impression on the examiner that the student or the candidate knows the evidence what he's saying. Okay. Thank you.
Thank you, Dr.
Sorry,
Deepak.
sorry, it was a bit more, but I wanted to
Thank
clear
you,
most
sir.
of the things. Okay. If any questions, you can ask now, or you can send to the First Academy. I'll be happy to solve those queries for you. Okay.